Good morning to one and all assembled here. Welcome to the clinical meeting from the Department of Obstetrics and Gynecology. We have 3 papers to be presented. To start with, our first paper is change of sequence beyond prediction. Actually, it's a clinical, really relevant and significant issue which we are going to deal with a series of cases, short and sweet. And maternal mortality is the national health indicator, and it's forming very important scrutiny by the healthcare providers and the administrations from the national level. So to look at that, we have presenting a few cases to show the clinical acumen and the readiness to tackle that will be done. Over to Dr. Lakshmi. She's going to present the cases. Okay.
A very good morning to one and all gathered here. I would like to present the cases, interesting cases. We'll like to discuss the case 1. She was a 34 years gravida to para 1 and living 1 with a previous cesarean section. 36 to 37 weeks of gestation. She was booked elsewhere at the regular antenatal checkups. She reported to ER at 9:50 a.m. to SRH with complaints of heavy menstrual bleeding per vaginum since 7:30 a.m. Before that, she was absolutely normal. She had a vigorous walk for 1 hour. Then she developed the bleeding and she reached home and reported to the primary care, and from the primary care she was referred to the tertiary care. On examination, she was very pale, paler plus and afebrile, and tachycardia was present. Pulse rate was 120 beats per minute, and BP was around 90/60. So on examination, uterus was term size and relaxed, but FHR showed bradycardia and profuse bleeding per vaginum was present. With previous records, was a post-cesarean pregnancy with no other comorbids. Ultrasound done a month ago, which was AFI showed 11 centimeter and fetal weight was 2.3 kgs. She was diagnosed a case of abruptio placenta with hypovolemic shock with fetal distress. Then what next? We planned immediate resuscitation. We called for help and then alert the OG, anesthetist, OT and neonatologist. Then fluid resuscitations and simultaneously blood was sent for investigations and blood and blood products were reserved. Then catheterization was done. Urine output was initially 100 ml and she was immediately prepared for OT. Emergency cesarean section was done, which was a crash section. And intra-op, it was a covalent uterus. RP clots of 9-10 grams was evacuated. Lycra was clear and adequate. She delivered a male baby of 2.8 kgs but with the poor Apgar of 0, 1 and 2 at 0, 1 and 5 minutes. And estimated blood loss was around 2000 ml. So intraoperatively 1 unit of plaque red blood cells were transfused, and postoperatively also the unit of plaque red cells were repeated. Then the placenta was sent for histopathological examination, which showed cholangiosis and acute and chronic amnionitis. On post-op day 3, we repeated hemoglobin. There's a drop, so again a parenteral iron infusion was given. So mother saved, but the baby outcome is poor. So diagnosis a case of severe abruptio placenta grade 3. The clinical significance in this case is the patient got delayed in seeking the medical emergency to the primary care. She waited for the ambulance nearly 40 minutes to reach the primary center and she was referred here for further management. So normal the fetal heart rate patterns in case of abruption depends upon whether it's acute abruption or chronic abruption. The main changes occurs in the acute abruption is the variable late or prolonged decelerations along with the fetal tachycardia. Then in case of profound marked hypoxia, we could see the sinusoidal pattern. In the above, we could see the recurrent variable decelerations with minimal variability. Then how we manage massive APH depends in the resuscitation and who should be included in the resuscitation team. It depends upon the ABCD as usual, but the D depends upon airway breathing circulation and D for decide delivery. The management depends upon the gestational age, whether it is less than 34 weeks or more than 34 weeks. Whether it's less than 34 weeks depends upon the grading. Whether it's a mild grade, we can do conservative management unless the maternal fetal status is stable, and moderate to severe, we like to deliver if the fetal distress or maternal instability is there. Then what it depends upon the blood components, whether what to transfuse, whether plaque red blood cells to be transferred, FFP to be transferred, a cryoprecipitate to be given, or platelet to be given. Depends upon the hemoglobin. Packed red blood cells you need cross matching, whereas FFB you need cross matching. Cryo we no need cross match. Platelet is also ABO compactability is enough, but ABO incompatible platelets can also be used with minimal risk. Usually we give, unless the blood reaches, we use the crystalloids and colloids. Crystalloids can be given up to 2 liters, whereas colloid can also be given unless the blood arrives. Blood can be given in emergency situation if cross match cannot be done. The group specific can be cross matched or an O negative blood can be given. Fresh frozen plasma should be given for every 6 units of PRBC, 4 units of FFP should be given. Or if prothrombin or APTT values are more than 1 point the normal, we can give FFP. Platelet should be given if the platelet is less than 50,000 per liter, or cryo less than fibrinogen than 1 gram per liter. We'll proceed to case 2. 20-year-old, primary, 34 weeks, booked at SRH and regular antenatal checkups and reported to ER at 3:45 a.m. with mild bleeding per vaginum since 3 a.m. but she was able to perceive fetal movements well. On examination, she was afebrile, pulse was 82 beats per minute and 120/80 mm of mercury blood pressure. Uterus was 34 weeks, relaxed and FHR was good, but a minimal bleeding PV was per vaginum was present. But PV was done with the cervix uneffaced and os closed, but NST was reactive. His previous records history of admission 2 weeks back for preterm pre-labor rupture of membranes query, an evaluation but no demonstrable leaking per vaginum was there. Ultrasound we did, Lycra was adequate and discharged after 48 hours and corticosteroids were covered at that time. She was known case of hypothyroid since conception and she was on thyroxine replacement. Ultrasound done follow-up after 1 week of the admission. Lycra it was reduced and estimated fetal weight was 2 kgs. She was diagnosed antepartum hemorrhage for further evaluation and advised admission. Then next we did, since there's no clinical evidence of preterm labor, fetal surveillance was done, but the NST showed reduced variability, so intra-uterine resuscitative measures were taken. Despite the NST showed reduced variability, IV fluids, blood and blood products were reserved and prepared for section, and intraoperatively uterus was normal, but the Lycra was blood stained and very minimal, and marginal separation of placenta noted. Delivered a male baby 2 kgs with good Apgar. Blood loss was 1000 ml. Diagnosed a case of abruptio placenta grade 1. Intraoperatively, because of PPH, we transfused 1 unit of packed red blood cells. Mother and neonatal outcome is good. It is a chronic abruption oligo sequence. The clinical significance is this: the fundamental cause, the chronic abruption, repeated intrauterine hemorrhage and subsequent subchorionic hematoma, which leads to hemorrhagic amniotic fluid and diffuse chorionic hemosiderosis. These causes the necrosis and the weakening of the amnion, leading to rupture of the membranes rather than the chronic abruption. The case 3, a 23-year-old, gravid 2, abortion 1, 34 plus 3 weeks. She was booked at SRH and regular antenatal checkups. Reported to ER at 10 a.m. with complaints of leaking per vaginum with bleeding since 8:30 a.m. She was able to perceive fetal movements well. On examination, afebrile, pulse was normal, normotensive. On parabdominal uterus 34 weeks and was relaxed. Fetal heart rate was good. On paravaginal examination, it was cervix uneffaced, os closed, no active leaking present. NST was reactive. Records available shows no other co-mobs. Ultrasound done 3 weeks back to diagnose of FGR stage 1 with estimated fetal weight of 1.4 and Lycra was adequate. She was diagnosed as preterm pre-labor rupture of membranes with FGR stage 1 with anemia. Last year was 10 grams. She was advised admission for further management. And then we hydrated and IV fluids, but no clinical evidence of preterm labor. Fetal surveillance was done. The admission NST was reactive, but the repeat NST showed fetal tachycardia. The intrauterine resuscitative measures were taken, but the persistent tachycardia was there for last 4 hours. So emergency ultrasound was planned, which showed a severe oligohydramnios of 2 cm and retroplacental clot of 8.8 cross 10.9 with a volume of 320 ml with a fetal weight of 1.6 kgs with less than 5th centile FGR stage 1. So diagnosed a case of concealed abruptio placenta grade 2, posted for emergency cesarean section. Intraoperatively, hemoperitoneum was 100 ml, Lycra was almost nil. Placenta fundal, large retroplacental clot of 300 grams evacuated. Male baby she delivered and 1.6 kgs with a good Apgar of 8/10 and 9/10. Baby is NICU and baby is doing good. And the no PPH and good outcome. Blood loss was 1000 ml, so packed red cells are given. Mother and neonatal outcome is good. This is a concealed abruptio placenta grade 2. The indications of emergency section in case of abruption is whenever the fetal heart rate is non-reassuring, we can do immediate delivery in order to prevent the hypoxia. In case of severe maternal hemorrhage, to control bleeding, we have to section and fail labor progression in fetal distress to prevent the fetal demise and suspect a uterine death. When should women with APH be delivered and what mode should be delivered? A senior obstetrician should always be present. The fetal death is already diagnosed, better to do vaginal delivery. The case 4, 31 years, gravid 2, abortion 1, 30 weeks, booked elsewhere with regular ANC. Reported to ER at 8 p.m. to SRH to gastroenterologist. She was complaints of abdominal pain since 2 days associated with vomiting but able to perceive fetal movements well. She was afebrile, pulse rate was 82 beats per minute and BP was 100/70 mm of mercury. On examination, epicast tendon was present, uterus was 30 weeks relaxed, FHR was good. With previous records, she is already known case of chronic pancreatitis and symptomatic pseudosis since 2 years, for which cystogastrostomy was done as PSG-IMS on regular follow with medical gastroenterologist at SRH since conception. She was a known case of rheumatoid and was low molecular weight apparent and lupase. Ultrasound obstetrics done 1 week back, it was absolutely normal with AFI of 14 and a weight of 1.1. Ultrasound abdomen done 4 months back, it was normal. It's a diagnosed case of acute and chronic pancreatitis of 30 weeks gestation with rheumatoid arthritis. So cross referral to obstetrician was given and requested for ultrasound. Patient developed bleeding per vaginum in the ultrasound room, which showed the ultrasound marginal separation of placenta, but the FH was good and Leica was adequate, weight of 1.4, hence shifted to OT for emergency section. Intraoperatively, blood stained Leica with marginal separation of placenta noted, but no significant retroplacental clot. She delivered a male baby of 1.4 kgs. No blood components were transferred. The good perinatal outcome. Abruptio placenta of grade 1, Cori anticoagulants use or acute infection. The postpartum monitoring of placental abruption depends upon the vital signs and uterine tone, vaginal bleeding, and hemoglobin hematocrit, and the coagulation profile and renal function. The vital signs has to be monitored initially. Uterine tone has to be monitored every 15 to half an hour after the delivery, and vaginal bleeding if any ongoing assessment. Hemoglobin should be monitored every 6 to 8 hours if bleeding is present, and coagulation profile has to be repeated every 4 to 6 hours in DIC risk, and renal function has to be monitored daily in order to prevent the complications. In case of anti-D should be given in non-sensitized RHD negative mothers. Then complications of abruptio placenta is mainly hemorrhagic shock, DIC, may go for hysterectomy and blood transfusion, repeated leading to reactions, and postpartum hemorrhage and acute renal failure. The main complications, the main thing in abruptio's last end stage is DIC. We'll see about the DIC. The main important, we have a scoring for pregnancy, which is based on International Society on Thrombosis and Hemostasis scoring system, which is a score of more than equal to 26 is DIC present. Mainly we take the prothrombin time and fibrinogen, which constitutes a major of this. The prothrombin difference is more than 1.5 seconds. It's scoring of 25, and fibrinogen less than 300 milligram per deciliter is 25. If this is more, the patient is diagnosed as DIC. We know thromboelastography. This is just a graph showing how the thromboelastography. This is rotum and TEG. This is the graph showing the comparison between the TEG and the rotum. This is the same thing. Then the normal reference, how the graph will be in case of coagulation factor deficiency, what in case of residual heparin, fibrinogen deficiency, and platelet dysfunction, hyperfibrinolysis. This is how the interpret rotum and TEG in case of all these things. Mainly the reaction time, K value, alpha angle, maximum amplitude, and lysis 30. In which we have to treat with. The reaction time is prolonged, we have to treat with FFP, and K value we have to treat with the cryo and fibrinogen. The alpha angle is reduced, we have to again transfuse cryo and fibrinogen. The maximum amplitude is reduced, we should give platelet, and lysin 30 is reduced, we should give tranexamic acid. Then significant obstetric emergency, because abruptio placenta is defined as the premature separation of the placenta from the uterine wall before delivery, leading to compromised fetal oxygenation, leading to maternal hemodynamic instability, then causes catastrophic hemorrhage, fetal demise, and maternal mortality. Then incidence of abruptio is 0.4 to 1% of all pregnancies, and 30% of cases with vaginal bleeding in third trimester. The risk factors, most important risk factors, history of abruption, previous abruption increases the 10 to 25 folds risk, preeclampsia 4 to 6 folds, and chronic hypertension 3 to 4 folds, smoking and drug abuse 1-2 folds. Main pathophysiology here is inadequate immunosuppressive activity in the placenta, leading to cumulative cytotoxic response, causing the aberrant implantation of the placenta and the decidual vessels rupture. How we could predict and prevent antepartum hemorrhage? Antepartum, can APH be predicted? Predicted cannot be done because it has heterogeneous pathophysiology. The most common risk factors is maternal age, low BMI, multiparity, preeclampsia, polyhydramnios, FGR, anemia, thrombophilia, nutrient deficiency, smoking, drug abuse, trauma, ART pregnancy, PROM, intrauterine infection, and previous history of abruption. With thrombophilia, the genetic factors, and methyl tetrahydrofolate gene mutation, and hyperhomocystinemia. The classification will depend. The diagnostic investigations we do normally ultrasound. The 4 pillars of management is communication, resuscitation, monitoring, and the delivery of the fetus. This is just a simple thing.
The placenta gets separated earlier, and actually it is the clinical diagnosis and readiness to receive, and everything, the equipment or the care provider is ready. It can be saved, the mother can be saved. The first patient only we have the poor neonatal outcome, but the resuscitation, the next day the patient, the attendants did not willing to continue, withdraw the support. So the baby is still alive, but definitely there is neurological damage. The main thing we have presented this case is a clinical presentation which can be varied, and luckily we got all the spectrum of the abruptio placenta to know what is the significance of that, and immediate attention and care will be definitely yielding a better outcome. Thank you for listening.
I'm going to present about cosmetic gynecology first. It's a new field, it's an emerging field. I'm just going to give a brief overview about the cosmetic gynecology and what is it. So the categories of cosmetic gynecology includes aesthetic procedures like labioplasty, clitoral hood reduction and vulvar lightening, functional procedures like vaginal tightening in case of vaginal laxity and with the usage of laser and surgical, and treatment of vaginal dryness, vulvovaginal atrophy and genitourinary syndrome of menopause, urinary incontinence like stress urinary incontinence, mild to moderate categories, and recurrent vaginal and urinary infections. Actually, these patients and menopausal patients, they suffer a lot and debilitating with these kinds of vaginal dryness, always a pain and incontinence, and recurrent urinary infections such vaginal infections. So we generally give the hormonal treatment, that too again with the side effects of postmenopausal bleeding and high risk of breast carcinoma. So we used to give the local estrogen cream, but still it is not helpful for them, for most of the people. So now with the emerging techniques like laser treatments, it's a vaginal laser. There are multiple varieties of laser like CO2 laser, Nd:YAG, erbium and diode lasers, and even the radio frequency can be used for the treatment of vaginal problems. So we have in our hospital as a diode laser with the vaginal accessories. Actually, it regenerates the tissue, it addresses both the aesthetic and functional concerns. It's a non-surgical and OPD based procedure. How the laser works, it increases the neocollagenogenesis, so immediate collagen contraction causing the tissue tightening, and neocollagenous elastogenesis over subsequent weeks for the long-term management. And it also boosts the blood flow, activates the fibroblast, builds new collagen. So it improves the, basically it improves the tissue health. It's getting more hydrated, nourished and more lubricated, hence restoring the normal vaginal pH and barrier function. And it gives a urinary symptom relief in case of mild to moderate category of stress urinary incontinence. It gives a vaginal support, also tighter urethral, periurethral and tissue support, so that it supports the urethra and bladder neck. And actually the session lasts for 10 to 30 minutes. It's they say it's a lunch break procedure. So, but again, it needs 3 to 4 sessions every month once, and again, it's not a one-stop solution. They need a maintenance treatment, because we are not going to restore their hormonal functions at the menopausal age. So it needs repeated sessions, and every year they need to have a touch-ups to maintain the vaginal health. So again, the PRP, that's all in all that we are using in the cosmetic gynecology also, that helps in the stress urinary incontinence, mild to moderate categories. It improves the vascularization even for the recurrent urinary infections or vaginal infections. It restores the tissue health. And again, it's a low cost, and it is not the only treatment. It is acts synergistically with the laser treatment and hormonal treatment, and everything adds together helps the women.
So just present few cases in urogynecological aspect.
First one is stress urinary incontinence. Here the patient involuntarily leaks the urine while they are coughing, laughing, even getting up from the bed, and a fast walk. It's because of the damage to the pelvic floor muscles during the delivery, and it gets aggravated during the perimenopausal age and even in the menopause. So the treatment depends on the grading of the stress urinary incontinence. From mild to moderate category, we generally start with a medical management with an SNRIs along with the Kegels exercises, but still the Kegels exercise helps as a preventive measure, not most useful as a treatment aspect. So coming to the surgical management, in case of severe cases, like even the patients when they walk and even when they're getting up from the bed or getting up from sitting position, they will leak the urine. In that cases, we go for a surgical management. There are so many sling procedures for the surgical management. This is one way. Transobturator tape. It's an easy, it's a daycare procedure actually. Our basic motto is to give a support to the bladder neck and the mid-urethral level. So the mesh, what we use is, it goes between the obturator foramen. So it's a small video about. So we basically inject a vasopressin to create a space and reduces the vasculature, and give a pubic incision on both the sides, the incision of adductor longus, and we give an incision 2 cm below the urethra and create a vaginal space on both the sides. Thus the needle we insert through the obturator foramen from outside in, and we fix a mesh with the needle eye and pull it out on both the sides. We do that. Again, needle on the opposite side. So this is the mesh on both the sides. So only thing to make sure that the space between the mesh and the vaginal wall should be there. It should not be very tight, otherwise the patient will end up in the urinary retention post-operatively. Again, it needs a redo surgery to cut the mesh. and then it closes. So actually the patient has an immediate effect within it's done in spinal anesthesia. So after 6 hours they will see an immediate effect. They try to cough and see that there is no leak. So far we have done some 8 cases and everything was smooth and they were very happy. So next is a Mayer-Rokitansky syndrome. There is an absent uterus and vagina, but the ovaries were normal for them. Generally, the treatment is before marriage, we advise a vaginoplasty for the marital relationship, but they can be a biological mother opting for a surrogacy. So vaginoplasty, there are so many types of vaginoplasty with using the skin grafting, ileal grafting, sigmoid colon grafting. But again, the skin grafting, they have some hair growth or the shrinkage will be there. For the ileum and colon, again, the bowel handling is there. This is a newer technique like Davido's procedure, peritoneal pull-through. We use the abdominal peritoneum as a vaginal epithelium. So actually, this is the absent uterus. They have only the vaginal fold inside. Above is the bladder and rectum. She is a case of polycystic ovarian syndrome because she was not menstruating. She was not diagnosed as a PCOS. Ovaries were very big, so we could remove some of the cyst. So here the procedure starts with the mobilizing the peritoneum anteriorly. That is the bladder. So we nicely mobilize as much as possible because we need the peritoneum to pull through the vagina. So we try to mobilize the larger part of peritoneum and the anterior wall, and this is the posterior part, below is the rectum. So we try to mobilize the peritoneum in the POD also. Always keep in front of that is the rectal fat. So we always go in front of it and mobilizing as much as possible. So the vagina is open. The vagina is open from down. So now the vagina is open. So we pull this is a vault, vaginal vault. It is pushed from the down. So now again the peritoneum is still more mobilized because we wanted more. And the vagina is opened. Now the peritoneum is getting pulled through the alice. It is inserted through the vagina. We pull it and we release the peritoneum, the side lateral walls to avoid kinking of the ureters because of pulling. So these are the utricles, the smaller underdeveloped uterus. We just mobilize it because to form an apex, because it's only the peritoneum closing the thing. So we need to form a tight apex. So we use the utricles on both the sides, anterior peritoneum and the posteriorly the peritoneum over the rectum also. All together we do a sturm of two sutures and tie it. So next slide. The main thing after the procedure is the post-operative care because they tend to re-stenose because of all the vaginal raw areas. So we use a vaginal mold for 48 hours to achieve hemostasis and maintain the patency. Then the vaginal dilators, the patient will be taught about the vaginal dilators. They have to use it 3 times a day, daily for at least 3 months to maintain the patency. After 3 months she came, she was an unmarried girl, 24 years, a nurse actually. After 3 months she came, we could see the vagina nicely forming pink. So we use the estrogen cream also to transform the epithelium. We have confirmed with the pap smear also. It's been transformed to the vaginal epithelium. She came 6 months back, married, and she's planning for surrogacy. And this is transverse vaginal septum. It's a congenital condition. Here the septum, these patients generally present at an early ages like around 18 years, 19 years because every month they have a cyclical abdominal pain. The blood won't be coming here. It gets collected in the uterus, so hematometra, hematocolpus, and even they go into endometriosis because of the spillage retrograde. So actually this patient came at 30 years because she was operated at 18 years. It got reached, there was only pinhole loss from where she was bleeding. So she thought it's normal, she's menstruating like that. So when she go for an infertility treatment, they found this much, again the restenosis of the vaginal septum. And they wanted a correction for the forming of the cervix so that they could do an embryo transfer. So it was a referral case. Actually, we did a correction again, the removed septum, the cervix, there is an anterior lip and posterior lip. And we could use a dilator. Again, the vaginal mold, everything was used for 3 months. After this, she went into an IVF treatment and got conceived and delivered. And this is the Ohvira syndrome. It's an obstructive, OH is obstructive hemivagina with ipsilateral renal agenesis. So these girls generally present late because one half of the vagina they are menstruating, the other half is getting collected. So they don't know the symptoms. Gradually they develop the abdominal pain, fever. She was around 20 years. She presented to us with fever and pain in the vagina and abdominal pain. So we could see. So there's a normal cervix other side. This is a pulled up cervix with a septum. Again, the same, the correction was done and it was maintained with the vaginal dilators for some time till it gets healed. Next is the wall prolapse, which happens after the hysterectomy due to hormonal issues. So our basic aim is to fix the vaginal wall to the sacrospinous ligament between the ischial spine and the sacrum vaginally. So this is a wall prolapse. We dissect the posterior vagina and rectum is medialized to avoid injury to the rectum, and ischial spine is palpated. Sacrospinous ligament is that's a shiny area. This is a sacrospinous ligament complex where the vaginal vault is fixed. It is done under spinal anesthesia, and bladder repair has to be done. And this is a laparoscopic pectopexy, other method. We select patients for this kind of patients with the mesh. Again, for the vault prolapse, we fix the wall to the iliopectineal ligament on both the sides. A small video about this. So this is actually vaginal vault which is pushed from down. It is the bladder and the rectum is carefully dissected away. This is the iliopectineal ligament on one side. Both the sides of iliopectineal ligament has to be dissected carefully because the external iliac vessels and operated vessels are in and around the iliopectineal ligament. So then the T-shaped mesh is inserted. The vertical limb is placed over the vaginal vault with a non-absorbable sutures, and both the sides T-shaped limb is placed over the iliopectineal ligament with a non-absorbable sutures, and we also use a tackers to fix it. These are tackers we use for the fixation in the iliopectineal ligament, and the peritoneum is closed to avoid the exposure of mesh inside the abdomen. So these are okay. These are okay. The patients with a prolapse in young women, nulliparous prolapse we say, or who have completed family even at the younger age, 30 years, 35, they don't want to remove the uterus. So we go for a Kana slings procedure. Because when the patient wants to get conceived even after fixing the thing, so this sling will be a good option. So here the bladder peritoneum is mobilized. Retroperitoneally the dissection was done and the mesh was fixed. So the final picture is this. The uterus will be like that. So even it's a dynamic sling. It is generally attached to the external oblique muscles. So they can get even conceived. They won't have any problem during the pregnancy because of the pulling of the uterus. I think it's fine. Thank you.
Very nice, madam. So interesting cases. Any questions? Lalitha, madam, you can load your slides.
I am a pediatric surgeon. In vaginal atresia, usually we get the babies present into OP with a large mass in the abdomen. Usually hematocarpus, sometimes it is infected, they present with pyocarpus. These cases we eventually end up with replacing placing the vagina with a segment of sigmoid bowel or ileum. Literature wise, in comparison with this peritoneal lining vagina, how does this do?
Eventually they will have a discomfort in that, but here in the peritoneal pull through, it is actually they are it's becoming more and more done now, because peritoneum is getting transformed to the vaginal epithelium nicely, and we could achieve easily the vaginal introiters achieve 2 fingers. There is no long-term problems. They don't shrink and they don't give us any problem. Actually the patients are very happy with that. Yeah, yes sir. Yes. We use a vaginal hysterectomy. It gets, because it's again the Mullerian part. I think there is a potent, they transform into a vaginal epithelium with the use of vaginal cream and all. The peritoneum. Yes sir, obviously. Thank you.
So any more questions? So I was about to ask the same question to us, so you asked. So any questions? Madam, the cosmetic gynecology seems to be overtaking the cosmetic dermatology. So what's your opinion on that?
Sir,
Because I see a lot of conferences on that, a lot of people interested on it, and the long waiting list for the training, probably the years. So what's your take on that?
Sir, actually, it's a newer emerging field. Maybe because of hype from the medias, people are wanting to, more people are wanting to have a solution for their problems. Again, the cosmetic gynecology, actually, it's a boon for the menopausal women. As I said, the laser, this is the main thing we are address. And about the dermatology, I don't think we overlap with the dermatology. They don't treat the vaginal part. Actually, gynecologist is the best to treat the vaginal part. Beyond that, I think it is fine for them.
Any questions? So no more questions. Interesting presentations, madam. Thank you. And over to Dr. Lalitha, madam, for your presentation on renal cell carcinoma and pregnancy. So I think she has given what is she is going to present.
Good morning, everyone. We are going to present a case of renal cell carcinoma in pregnancy. We are presenting this because of the rarity of the case. Actually, this patient is only a 28-year-old lady who has had 3 pregnancies which were treated in this hospital. So I'm going to ask Dr. Niveda to tell about this patient.
Good morning, everyone here. We are here to present the case of renal cell carcinoma in pregnancy, which is a rare case. Introduction. Renal cell carcinoma is a very rare condition during pregnancy. The incidence of cancer during pregnancy is 0.1%, of which breast and cervical cancer are more common than gastrointestinal and urological cancers. Only 100 cases of renal cell cancer in pregnancy has been reported as per literature. Our patient is a 28-year-old female. She had 3 pregnancies with renal cell carcinoma. A case report, she is a 23-year-old primigravida with 3 months of amenorrhea and right loin pain. She was diagnosed to have an early pregnancy with an anembryonic pregnancy with right renal mass. She was confirmed with CECT abdomen. It was a large heterogeneous mass of 13 into 8 cm, occupying the inner and lower pole of the right kidney with exophytic lesions displacing the bowel loops and mass descending into the renal sinus, of which she belongs to stage 2 of renal cell carcinoma. Then patient underwent radical nephrectomy in SRH by Dr. Ganesh Prasad sir. After investigating and after termination of the pregnancy of 10 days later, she went the radical nephrectomy. Histopathology reported as clear cell carcinoma. Then patient was followed up by sir by regular intervals of 3 months. And no further treatment was required for her. Then she became pregnant after 2 years, which was a spontaneous pregnancy, and she had an uneventful antenatal period, and she had a normal full-term vaginal delivery. Then her 3rd pregnancy was in 2025, and she had an antenatal checkup in Gudalur till 32 weeks. She came with severe FGR and Doppler changes, and she underwent LSES, and which was an alive preterm baby, which is in NICU for the preterm care. Discussion about this case. The incidence in India is 2 per 10,000 males and 1 in females, and approximately it is 85% of the cases are clear cell carcinoma in renal cell cancers. It is more common in 5th and 6th decades. Symptoms, it is usually a clinical triad of flank pain, hematuria and an palpable mass, but it is an incidental diagnosis, and diagnosis is mostly by ultrasound. Then later we'll go for CECT abdomen. But in pregnancy we have to do MRI, but this patient, since she has an anembryonic pregnancy, she underwent CECT abdomen. The treatment strategies depends upon the patients and her gestational age. In literature, it was said that if a patient has 16 weeks of pregnancy, she underwent laparoscopic nephrectomy and she had a term delivery. And one patient had after delivery, she had underwent radical nephrectomy. So the treatment depends upon the patient. The pregnancy complications are, there will be pain, hematuria, hypercalcemia, and hemolytic anemia, tumor rupture, and FGR in the fetus. The 5-year survival rate with renal cell carcinoma is 50 to 70%. Even with stage 1, they has up to 90% of survival. And the take-home message is, this case, we have to do an whole abdomen scan in the early weeks of pregnancy, not only the pelvic scan, so that we could diagnose such cases. Thank you.
As told, there are no guidelines for the treatment. The treatment is only individualized. Actually, this patient was treated by radical nephrectomy by Dr. Ganesh Prasad in our hospital. So I request Dr. Ganesh Prasad to tell a few words.
That was a nice presentation. Thank you, ma'am. Actually, this patient was a very, very young female, 20-year female. And during COVID time, 2020, she walked into the hospital. She said, I am pregnant, and in incidental scan showed a renal tumor. So I got aborted and I'm coming here for treatment. So like any other renal malignancy, we thought in terms of clear cell carcinoma, which is the most common type of renal cell carcinoma. But after doing surgery, we had a surprise that there were areas of renal synovial sarcoma. So in the histopathology, I think Dr. Sethu will be remembering it, if Dr. Sethu is there. So this patient had a histological renal synovial sarcoma, which is a very, very rare entity, 1 in 1 lakh. So there are no cases reported in South India actually. We sent it for immunohistochemistry, which showed a positive staining for a synovial sarcoma. We sent for gene translocation to CMC Vellore. We took the genetic analysis, sent for gene translocation, and there was a translocation of gene 18. Chromosome X and gene 18 translocation was there. And if BCL2 is seen in the immunohistochemistry, then this patient has to undergo chemotherapy in the form of ifosfamide. Ifosfamide is required. If BCL2 is negative in the immunohistochemistry, she has to undergo radiation therapy. So we offered these two treatments after doing surgery. But she said in one word, I don't want any of these. I will come for regular follow-up. So leave me alone. Don't give any of the chemotherapy or radiation therapy. So we went along, but a very sincere patient. Every 3 months she used to come for regular follow-up. I asked them to avoid pregnancy for the next 2 years. Please don't get pregnant for the next 2 years. She followed it regularly. She was pregnant again. First time she was on regular follow-up, but after first pregnancy she became very lax. She didn't turn up for any follow-up, landed up with all the complications now during this pregnancy, and madam has ably managed her and sent her home very well. So now she is having a single kidney. So my issue is she should not go on for any acute tubular necrosis or acute renal failure during the pregnancy or postpartum. She was ably managed and went home well. Thank you. Yes, sarcoma.
What is anembryonic pregnancy? Anembryonic pregnancy. What is
That's right. I think they have to answer.
It's a big, otherwise called as miscarriage.
So this is a carcinoma sarcoma. No, anyway, so it is one of the sarcoma. So we see this often in, not oftenly, so then we see in lung samples in the kidneys. So I think oncology is here. So you can comment on carcinosarcoma. Before Dr. Jayapal is already ready. No, but the terminology is carcinosarcoma.
Carcinosarcoma we see in the uterus also. That is from the Mullerian origin. Synovial sarcoma of the renal.
So any more questions? So over to Dr. Jayapal for his interesting presentation. Achha, you changed your topic now.
We didn't change it. Actually, the topic
So we have changed. Okay, so over his interesting presentation on liver transplantation at SRH. So you are standing today to present it.
So, good morning, everyone. I'm very happy and thankful for presenting this clinical club on our team's behalf. So, to start with, I want to introduce to the topic of liver transplantation through a set of photos. So, on opening the abdomen, this is what we see in all cirrhotic patients, where we encounter a shrunken, nodular and cirrhotic liver with evidence of portal hypertension in the form of multiple collaterals in and around the liver. These patients are generally sick with coagulopathy, excessive bleeding massive ascites, splenomegaly and thrombocytopenia. This is after the entire liver has been taken out, which we call it as explant hepatectomy or a total hepatectomy, leaving behind the IVC with the clamps on the right hepatic vein and the middle hepatic vein, left hepatic vein confluence. This photo shows it even better. This is the IVC after taking out the liver, and all these small stitches are after dividing the short hepatic veins which drain the liver to the IVC. And the clamp, the right clamp is on the right hepatic vein, and this one is on the middle hepatic vein, left hepatic vein confluence. Can video please? And this shows the temporary portocaval shunt, this one, where the portal vein was temporarily anastomosed to the IVC to avoid mesenteric venous congestion, and it gives us some time to implant the liver. This is not done routinely in all cases. In cases where we expect a mesenteric congestion, we do these things. And in cases of cadaveric liver transplant, we retrieve the liver from the brain dead patient, and we do a procedure called benching, where the liver which is taken out from the cadaveric liver will have excess fat around the blood vessels and in and around the liver. So we retrieve the liver and bench it, where we remove the excess fat around the vessels. So this is the celiac axis, and this one is the left gastric artery. This is a common hepatic artery and gastroduodenal artery. Excess fat has been separated off. This is the portal vein. And after preparing it in the bench, can we go a slide please? Okay. So this is how a liver will look like after implanting before reperfusion, where the liver is cold and pale right now. And after reperfusion, the liver will look bright pink and well vascularized. So this applies for cadaveric liver transplant or DDLT. In LDLT, what we do is we remove a part of liver from the donor, which is right lobe for the adult liver transplants and left lateral section for the pediatric liver transplant. The line marks the transection line, which is called as the Cantley's line, which separates right and left lobe of the liver. So this is after separating the right lobe and the left lobe, and it's only hanging with the right hepatic vein. And once the graft is taken out, again here the segment 5 and segment 8 vein will be reconstructed at the bench to form a new MHV. And this is a remnant liver in the donor, and this is the IVC with the left lobe, and all you can see is a nice field with no blood in it. And this is the reconstructed new MHV and the right graft implanted into the recipient. And this is again a graft, venous graft used for forming the new MHV. So video please. So this video will show the new MHV, where you can see the respiratory oscillations on the middle hepatic vein, and this is the portal vein which is anastomosed. This pulsatile artery is the right hepatic artery which is anastomosed. This is the bile duct which is yet to be anastomosed, which is will done after performing the vascular anastomosis. So liver transplantation as such is a complex operation, and high risk group adds even more complexity to the operation. High risk groups can have, I don't want to go into the individual particulars of all these patients, but high risk group will have poor outcomes as compared to the routine risk patients. And high risk group can be from the patient as well as from the donor considerations. The general transplant outcomes are with 90 to 95% success rate. Whereas in these high risk groups, the success rate drops down to 80 to 85% because of the multiple factors involved in it. So our full team started doing transplants on our own at Ramakrishna Hospital from 2023. And in July 2023, this is the first case we performed, which was performed by our in-house team. This patient had been in the waiting list for a long while, almost for 1.5 years have been waiting in the list. And he had recurrent admissions for hepatic encephalopathy and hepatorenal syndrome. So we got an organ which was marginal, and it was not our hospital stent, but was the previous hospital stent, which was rejected by them because of the marginality of the organ. We say marginal, it's because of the visual fat estimation in the liver, which was around 30 to 40%. Once we got as a second turn, we don't want to miss it out for that particular patient, because losing his turn, he would have waited another 8 months to 1 year, where he would have succumbed to the disease as well. So he had hiccups in the initial post-op with the coagulopathy, because he had initial early allograft dysfunction, and at that time his coagulopathy was managed with monitoring the fibrinogen INR APTT levels, and we did not have a rotum at that point of time, but promptly our hospital helped us in buying a rotum in the next few months only. And second case was our first LDLT, successful LDLT at our hospital, which again the patient was very sick with refractory HRS, where he had fluctuating creatinine ranging between 2 and 2.5 with refractory ascites. And since his creatinine was always on the higher side, with the strong nephrology backup, it was planned to have a sled immediately if required. And in all these high-risk patients, the important factor will be to have a good intraoperative flow of the surgery without any major hiccups, like no excessive bleeding, and the anesthesia monitoring at the head end, where the BP fluctuations and pulse rate fluctuations should be kept to the minimum. And fortunately, this patient did not require a sled, but CRRT offers a more better and smoother form of removing the dialysate as compared to the sled. And right now we have CRRT as well, and these kind of high risk patients can be treated even better right now with the use of CRRT. So, and then we had one donor in the last 4 years which was in hospital. We are trying to push the organ donations in the hospital. So this particular donor was split for the pediatric patient and as well as the adult patient, and the pediatric patient was from our hospital. So this was the first pediatric split liver transplantation in our region. It was for a post-Kasai biliary stricture. The child did not have any family donors, so he was waiting in the list, and then we could do the split liver transplant successfully. The first picture shows the anesthesia team in action in full swing. This is on post-op day 1, where the child was extubated and was recovering in ICU with the help of PICU team and the neonatology team. So, and then subsequently, we had a patient who was 72-year-old with hepatocellular carcinoma, the hilum, having a bilirubin of 21. He did not have a same matched blood group donor within the family, but the family wanted to go to any extent for his father, and so the son came forward to do a ABO incompatible transplant. ABO incompatible transplant generally will have higher spending and higher complication rate because of the initial rituximab they receive in the plasma exchange, which makes them more prone for infections. So this patient, after 4 sessions of plasma exchange after the initial rituximab injection, was taken up for a ABO incompatible liver transplant, which was done, and he recovered successfully. Plasma exchange is being routinely done with a strong nephrology backup in our hospital for ABO incompatible transplants for ALF and ACLF, all these patients. And then we had the next patient we had was for a retransplant, where initially he underwent living donor liver transplantation at Chennai, and then that living donor transplanted liver again went into cirrhosis after 5 years. He was then listed here and then got an organ from the common pool. This is the explant liver. It shows this is a right lobe graft which is completely shrunken and nodular, and he received a whole liver donor from the cadaveric transplant program. The complexities in retransplant is that in the previous transplant operation, they would have used the portal vein and the proper hepatic artery or the right hepatic artery. So we were ready to put a jump graft from supraciliac aorta, and then IVC was also prepared for a complete replacement. But we could get away with a difficult explant hepatectomy without injuring the IVC or without the need for putting a jump graft. The transplanted liver, we could isolate the common hepatic artery as the inflow, and then IVC was left in situ. So then our living donor liver transplant program picked up steam, and we started doing living donor liver transplants more regularly. And this patient, after doing 10 transplants, we received TN health insurance scheme, which was again a support for our group of patients. So this particular patient was the first case done under TN scheme, but he had ACLF with a bilirubin of 21 and high MELD with a MELD score of 36. We call it as high MELD when the MELD score exceeds 20, and if MELD is more than 25, they have a higher risk of 3-month mortality rate. So this patient had only one family donor who had anatomical difficulty in the form of 3 bile ducts left to reconstruct, and again the graft versus weight ratio was again borderline. We expected GRWR of 0.7 or more for a very successful outcome. In him it was borderline. So for him to do a successful transplant, there has to be minimal blood loss with a smooth operation, and all the ducts has to be meticulously anastomosed. And this is the right anterior sectoral ducts, 2 ducts, and a posterior sectoral duct, single duct. All 3 were anastomosed to the common bile duct. This patient, more than the technical feasibility, He was evaluated and listed for transplant, planned for transplant, which is in Chennai at a center which was considered as one of the world's best center. But he kept coming back to our hospital because the cardiology backup or the cardiology support was not very welcoming for him. He had a triple vessel disease, and he was in multiple hospitals in Chennai and Delhi for getting a transplant done, but none of the cardiologists there gave a clear go-ahead for a transplant, and always he was kept in the loop for a triple vessel stenting. So here our cardiology team backed us and pushed us in doing the transplant, and we were able to do his procedure successfully. Intraoperatively there are very less blood loss, around 780 ml with no blood transfusion requirements, and he recovered well and got discharged within 2 weeks of surgery. So this is for a pediatric hepatoblastoma patient, which was involving the caudate lobe and the confluence of all three hepatic veins. After the neoadjuvant chemotherapy with doxorubicin cisplatin, he was, after the tumor shrank in size, but still the tumor was still encircling the IVC, which was seen here. This is the tumor which was encircling the IVC in the caudate lobe. We were prepared for a IVC replacement, but slowly we could meticulously take out all the caudate lobe which was wrapping around the IVC with a clear negative margin. So this is a child who recovered and got discharged within 14 days, and at the time of discharge was this photo. So this particular patient had a very high bilirubin and was having ACLF, was severely sarcopenic, lost around 30 kg in the 2 months time. He also had a single donor who had 2 arteries and 2 bile ducts to reconstruct. With the ACLF background and a difficult anatomical reconstruction, most centers refuse, but this will be his only pathway to recovery or a second life. So we took this patient considering the risks. He promptly developed a CMV infection, but we could manage that by picking it up early, and in coordination with the ID team, we could treat that patient successfully. He subsequently developed biliary stricture in 4 months time, because all these risk factors will lead to biliary stricture, which we anticipated also having a biliary stricture rates of 20 to 30% in this group. But with a single metallic stent by our competent MGE team, he still is now symptom free and is recovering well. So this is a patient with HPS with the ambulatory home oxygen, was sarcopenic. She got a donor alert with a 72-year-old organ, because generally we accept donors till 70 years in cadaveric program, but 72, and the liver was looking old, but we gave it we thought it would be a chance for her, only chance for her. So she recovered well. This is a post-op day 1 where she was extubated and kept in high flow, and she was off home oxygen now, and she is ambulating, gained weight and looking well now. So this is the case which was done last month. More than the technicality, it's the management's will to work with another hospital to save 2 patients of their unnecessary cost and ABU incompatible transplants, and able to, with both teams coming together to coordinate and do successful liver transplantation, will open new avenues for more patients. So we have done 27 cases till now. We had 2 mortalities, one for an ACLF patient who had a donor sepsis and another patient who had ILD, which required a combined lung and liver transplant, but which was not feasible practically. So he went ahead, but initially he recovered well, and later after 2 months he died. And with the 92% success, 5% success rate for our patients, most of our patients were in the high risk group, because of the 27 transplant we did, 15 were falling within the high risk group. So this going forward, this is going to be our mission, where we want to have an aftercare program for the liver transplant, but wanted to start a dedicated liver ICU, wanted to establish a pediatric liver transplant as a separate entity, and with management help, with organ donation rates getting better in our hospital, we are able to serve more patients to help them save cost as well as save their lives. With increasing volumes, we would be hopefully reach to do donor or laparoscopic robotic donor hepatectomies, and our aim and every time will be to offer affordable liver care at its highest quality. So liver transplantation is a technically complex operation, but it's not a difficult operation. So with the right mindset, which is serving our patients with the best possible outcomes and at an affordable rate, and with a dedicated team which is already set, with a strong support system in the form of physiotherapy, OT nurses, ICU nurses, physician assistants, and with all strong allied departments where they constantly help in getting these patients recover, and a very supportive management, we are very hopeful that we're going to be one of the best programs in our region as well as in the state. And thank you for this opportunity. Thank you.
Thank you, Dr. Jayapal, for the interesting presentation. So Dr. Prashanth can load his presentation. So any questions?
He's well known. Transplants for hepatosomal carcinoma is an established fact. So, we are within the criteria. If we do transplants, the outcomes are as similar as the patients who don't have a HCCS. Patient selection.
Is immunosuppression not that much required after liver transplant as compared to renal transplant?
As compared to renal transplants, immunosuppressions are less cumbersome, and there are immunosuppressions are less in number in liver transplant patients. After a year, most patients will be on a single immunosuppression drug, but that single immunosuppression drug they have to take lifelong.
We had in pediatric surgery biliary atresia. In 90s, we had several cases, and after 3 cases survived up beyond the age of 20 without liver transplant, and now a few years back they all had liver transplant done at Chennai. It was not introduced here, I believe, then, and they are doing well, doing very well in their profession. And what is the cost of a liver transplant?
Within scheme, we are doing it within scheme, sir, without charging extra. For a non-scheme patient, the cost ranges between 16 to 17 lakhs in our hospitals.
What is the percentage of the liver you harvest from the live donor?
We take up to 60 to 70%. Sir. The remnant should be at least 30%. The remnant is the remaining part of liver which is left within the donor should be at least 30%.
How long does it take for the liver to regenerate?
Generally 2 to 3 weeks.
2 to 3 weeks only. It assumes the same 1.5 kilograms.
It's not about the weight, sir. It's about the adequacy for our body
function. Until 3 months, how do you support?
We don't support, sir. After discharge, donors will not be on any medication. They will be asked to visit us in 1 month time and 3 months time, and that's all they are going to take. So the liver regenerates with a good diet and proper rest.
Thank you.
Thanks.
Thank you, sir. And Dr. Jayapal, don't you think that the second redo transplant, the cirrhosis happened was too early?
So generally, 5 years time is a little short for a liver to become cirrhotic again, but it depends on the root cause. That patient had autoimmune hepatitis. He had a flare and then had a.
So it is the reason why the first transplant underwent led to the second one. Okay, why you choose right liver in the right lobe in the adult and contrary on the
because
pediatrics?
Of the volume, sir. Our radiology team will give us the weight of the right lobe as well as the left lobe and the whole liver volume. So right lobe weight should be adequate for the recipient, because if the recipient weight is 70 kg and the right lobe weight is say 490 grams, the GRWR will be 0.7, which is the bare minimum requirement for proceeding with the transplant.
Dr. Anandbaran had some come or under the other presentation. Okay, so over to Dr. Prashanth. Thank you, Dr. Jayapal.
A very good morning to one and all. I am Dr. Prashanth, surgical gastroenterologist from the HPB team of a hospital, and I am going to showcase a case of laparoscopic spleen preserving distal pancreatectomy done in our hospital recently. A 22-year-old unmarried female came to us with complaints of epigastric fullness and early satiety. She was diagnosed elsewhere with a cystic neoplasm of the pancreas, for which she was offered the conventional distal pancreatectomy with splenectomy. However, she denied surgery because she was not very keen on getting her spleen removed. So she opted for aspiration, which she underwent twice, but then she developed recurrence. So after this, she came to us and we did a CCT abdomen, which showed a lesion of size 9.5 into 9 into 9 centimeters in the tail of pancreas, which was compressing the stomach. There was no wall enhancement mural nodules, and internal septation. So this shows that the cyst was benign with not much evidence of malignancy. Play, sir. So we can review the CT images. Yeah. Pause. Yeah. In the CT image, in the first image, you can see the cyst is there in the tail of pancreas. It contains clear fluid. And on the second image, you can see it compressing the stomach. And on the third image, you can see the splenic vein going into the spleen with the cyst on both sides. So on imaging, as the cyst appeared benign and the histology of the previous aspiration was suggested the same, benign, she was offered a spleen preserving laparoscopic distal pancreatectomy, despite the technical difficulty because of the large size of the cyst. Play. Yeah. In this image, you can clearly see why people usually use. Sir, previously. In this image, we can clearly see why people use the conventional distal pancreatic splenectomy approach, because it is preferred because of the close proximity of the splenic vessels traversing just posterior to the pancreas into the spleen. Because of the cyst was benign, we offered a spleen preserving approach. Here we literally have to peel the pancreas from the vessels, making sure to ligate each of the branches going into the pancreas. Play. Yeah, so after the port position, we enter the abdomen. Here we can see the cyst being covered with the omentum, the transverse colon at the bottom and the stomach above. It is being adhered to the lateral abdominal wall, and these adhesions are being released slowly. Then we go to the superior aspect, where we enter the lesser sac by cutting the gastrocolic ligament. So after the gastrocolic ligament is cut, we enter the lesser sac and we can see the cyst clearly. The superior border of the cyst is being defined from left to right direction towards the splenic hilum. The same thing is being done now in the inferior aspect. Here we retract the transverse mesocolon and cut the omentum so that we can access the inferior part of the cyst. Here also we proceed from the left to right towards the splenic hilum. Now we can see the inferior border of the cyst being defined well. Here in the next step, we try to lift the cyst off the transverse colon and transverse mesocolon. And we try to access the posterior aspect of the cyst. However, here you can see the cyst is very bulky. So accessing the posterior part is very difficult and we have a limited view over here. Hence, we plan to proceed with aspiration of the cyst. We plan to deflate the cyst next. So we are deflating the cyst with a Veress needle. We make a small puncture hole. After this, we enlarge the puncture hole and we suction all the contents out. So once the cyst is deflated, we seal the puncture hole with 2 clips to prevent further leakage. So now after this, we can easily see how easy it is to maneuver the pancreas along with the cyst. And the posterior access, which was previously very difficult, is easily entered. And so now we continue with the dissection, lifting the pancreas from the retroperitoneum towards the splenic hilum. And now we alternate, we go to the superior aspect of the pancreas. After the deflation of the cyst, the splenic artery comes into clear view. We can see an image now showcasing the splenic artery with its branches. So here now our aim is to preserve the splenic artery and slowly peel the pancreas using a thunder beat from the splenic artery and ligating each of its branches. Any bleeding encountered during this step is dealt with the bipolar artery. So, and after further dissection, the splenic vein comes into view, and we treat the splenic vein the same way we treat the splenic artery. We preserve. This is the diagram showing the splenic vein. We preserve the splenic vein and slowly again peel the pancreas from the splenic vein, making sure to ligate each of its branches going into the pancreas. So same way the dissection is always from the left to right. Here in the image we can see the splenic cyst on both sides of the splenic vein. So the splenic cyst wall is slowly being dissected, preserving the splenic vein. We use a right angle instrument to slowly peel the splenic cyst wall from the splenic vein. Sorry, pancreatic cyst from the splenic vein. Now we alternate and we go to the inferior aspect. We access the splenic artery from the inferior aspect of the pancreas. Here we will see an image where it shows the splenic artery. We alternate between superior and inferior accesses. It gives us a better view of the arteries and allow us to deal with any bleeding or any untoward event. Here we use a thunderbeat over here because of its good hemostatic property and minimal lateral heat spread. Meticulous dissection and patiently doing it is the key to this surgery. However, despite our efforts, we encountered with a small bleed from a branch of the splenic artery. This bleed was temporarily dealt with using a bulldog clamp. The bulldog clamp is applied to the branch of the splenic artery, and then we continue with the dissection. Here the splenic cyst is being peeled off from the spleen at the splenic hilum. The problem here is the splenic artery diverges into multiple branches, and it is important to preserve as much of the branches as possible. And after this, we put a bulldog in the main splenic artery, and the superior and inferior planes of dissection are being connected over here in a location medial to the cyst, where we can give like adequate margin. The pancreas is now being lifted off the splenic vessels, and with the help of an endo-GI stapler with graded compression, we are able to transect the pancreas. And after transection, the remnant pancreas with its adhesions which are left over are being cut, and the specimen is being retrieved. This is the last adhesion of the cyst to the vessels which is being cut. And after this, now we deal with the splenic artery branch which we had temporarily stopped with the bulldog. We plan to suture it with a 4-0-proline laparoscopically. During this, you can see a wedge-shaped infarct which has occurred in the spleen in the middle part of the spleen. But this generally does not have much of significance or consequence postoperatively. And now the transected pancreas is being sutured over here. We mainly suture it only where there are bleeding points. These are hemostatic sutures which are being taken. This is not proven, but some people believe that it can decrease the cause of postoperative pancreatic fistula. Then after thorough wash, we can see the preserved splenic vessels going into the spleen. We ensure good hemostasis. We retrieve the specimen in the specimen bag, and we place a drain in the pancreatic bed near the vessels. Pause. This is the postoperative course. The patient was, he had a normal postoperative course. The patient was exhibited on table. On POD 1, oral liquids were started, increased to semi-solid diet gradually. We took a Doppler of the splenic vessels, which showed a good flow on POD 1. And on POD 3, the drain fluid amylase was a bit high, 400. However, he had no symptoms, so we could label it a biochemical leak. And on POD 5, the drain fluid amylase was normal, and the drain was removed later. On POD 7, the patient was discharged, and later the histopathology came as a benign mucinous cystic neoplasm of pancreas. So we thank you for this opportunity.
Thank you, Dr. Prashanth. Questions?
This particular patient was diagnosed some 6 months back. Everywhere she went, she was offered distal pancreaticosplenectomy. She was a young unmarried female. She doesn't want to have a splenectomy, and then kept in search for a team which does only distal pancreatectomy. Fortunately, we have consent her for a splenectomy because intraoperatively we can still could end up with doing a splenectomy, but we put our best efforts in doing only the distal pancreatectomy.
Dr. Anand Bharan.
I'm tired talking actually. Stop talking these days. So I've got colleagues who have said everything I need to say, and I would say thank you. Thanks. I'm very grateful to the management for supporting them. So I'm here till they need my support.
Any questions? there no more questions, we'll close today's session. And thank you all for wonderful presentations today.